other topics. First, in the developmental disturbance, what are we expected to know? We are expected to know that the basic concept of difference between an hamartoma and a coriostoma. A hamartoma and a coriostoma. That is what we are expected to know. All of us know what is hamartoma basically. Hamartoma is nothing but the proliferation, benign proliferation of cells, basically native to that place. Whereas coriostoma is benign proliferation of cells not native to that place. All of us know the typical example of coriostoma, that is Fordyce's granules. Fordyce's granules. Okay. Now, here we are supposed to know the concept of natal and neonatal teeth. Usually, typically, what they give is they'll show a infant's tongue with an ulcer on the ventral surface of the tongue, with a sharp tooth in the lower anterior region, which could be a natal or a neonatal teeth. All of us know the difference between natal and neonatal teeth. The teeth which appear at birth is natal. Within first month of life is the neonatal teeth. That natal or neonatal teeth will cause a Rigafett disease, which is nothing but an ulcer on the ventral surface of the tongue. That is a typical image-based question you are expected to identify. Now, what is this exactly, this Rigafett disease? It is a part of one big group called as TUGSE, traumatic ulcerative granulomatous with stromal eosinophilia. Here, one important point I have emphasized here, that basically in TUGSE you will see an ulcer, and that ulcer will rapidly heal after biopsy. How to differentiate that this is TUGSE or a malignant ulcer? You do an excisional biopsy, the TUGSE will heal completely. However, if it would have been a malignant ulcer, the ulcer will not heal with that rapid time, or we can say with that fast nature. So it will take some time, or it doesn't heal it up. That's a basic difference that we are supposed to know between the, and that is a question that's a highlight that has been asked as an important point. Now, all of us know about the hairy tongue, where it is a hypertrophy of the filiform papillae. And one other important syndrome here, Peutz-Jeghers syndrome, that very frequently comes. What are we supposed to know about Peutz-Jeghers syndrome? Mainly is that there will be perioral pigmentation. Perioral pigmentation. Here, what they will give you is, they will give the pigmentation in some other location. Tongue is the most common site. Okay, exactly, that is not the point. You have to remember here that tongue is not, or intraorally it's not the most common site. In Peutz-Jeghers syndrome, P for P, perioral pigmentation or perioral freckling is seen. And it is autosomal dominant, and we will see intestinal polyps mainly in the jejunum in Peutz-Jeghers syndrome. Okay, next, geographic tongue. What are we supposed to know? Geographic tongue, we are supposed to know that basically geographic tongue is nothing but the red areas that you see basically. Those are the red areas on the tongue, and those red areas will have serpentinous borders. Those words, serpentinous, is very important. What do you mean by serpentinous? Serpentine, snake-like. Okay, wavy borders. So the red patch or the red areas with serpentinous borders, and which is classified as a psoriasiform lesion, is a characteristic feature of geographic tongue. Why exactly we call it as psoriasiform lesion? Because it will have the Munro's abscess, intraepithelial microabscess, which you see in psoriasis, Munro's abscess. The same Munro's abscess is even in geographic tongue. That is the reason that you call this geographic tongue as psoriasiform lesion. Even one of the favorite topic is image-based question on Epstein pearls and Bohm's nodules. So what are these exactly? Epstein pearls and Bohm's nodules. We are supposed to remember that these are white colored nodules that is seen on palate. The question comes the location. If you see the nodules along the mid-palatine raphe of the palate, it is Epstein pearls. There's a question here like, if white patch also called geographic tongue, basically white patch is seen in geographic tongue, but predominantly you see red areas, because in geographic tongue also there will be depapillation. There will be depapillation. You will see, of course, white areas, but characteristic in geographic tongue will be the red areas. Whereas now coming back to Bohm's nodules will basically have the white colored nodules at the junction of hard and soft palate. So the main difference between Epstein pearls and Bohm's nodules is the location of those white nodules. How to differentiate from this from newborn cysts? Okay, we know that there will be some cysts, odontogenic cysts, that you see basically in case of the newborns, because those are seen in the tooth bearing area, alveolar region, white color nodules. Whereas in case of Epstein pearls and Bohm's nodules, you see them on the palate. Another important topic that will be usually emphasized or they'll ask you is cleft lip, cleft palate. Here, cleft lip, cleft palate, typically questions are asked on genes. Genetic aspect is very, very important. If there's a doubt here that if it is a seen on the middle of the tongue, then what is the cause? See, basically, geographic tongue, the depapillation will not be located to one area. The depapillation will be shifting. The depapillation will be shifting. If it is in one area, central area, then it is not called as geographic tongue. Geographic tongue or wandering rash means the red areas will shift. Cleft lip, cleft palate. Genetic factors we are supposed to know. Mainly the genes, that is MSX1 is the main gene that we are supposed to know. And there are many other genes. One of the important gene is IRF, interferon regulatory factor 6. Interferon regulatory factor 6. This is the gene that is mutated in a syndrome called as van der Waals syndrome. Okay, all of us know about this syndrome, van der Waals syndrome, that you see lip pits in this syndrome. Lip pits. We are supposed to remember the names of the syndromes and the anomalies. Like Talon's cusp, you will see the Rubinstein-Tybee syndrome. In Klinefelter syndrome, you will see taurodontism. In double lip, where do you see double lip? Ascher syndrome. Lip pits is seen in case of the van der Waals syndrome. Okay. Melkersen-Rosenthal syndrome is again a very important topic, where we are supposed to know that here this syndrome is mainly associated with the facial paralysis. Mainly it is associated with the facial paralysis, fissured tongue, and cheilitis granulomatosa. The triad of Melkersen-Rosenthal syndrome is again a very, very, very favorite topic. Triad. What you will see? You will see the fissured tongue, you will see the Bell's palsy, you will see the cheilitis granulomatosa in case of Melkersen-Rosenthal syndrome. Moving on to the next topic here, which is usually asked is the benign and malignant tumors. What are you expected to know here? Typically, you should not forget. These are like these topics which I'm discussing are like you are supposed to know this. Malignant transformation rates. Like, what is the malignant transformation rate of homogeneous leukoplakia? It is only 1%. What is the malignant transformation rate of speckled leukoplakia? 2 to 4%. Malignant transformation rate of erythroplakia. Malignant transformation rate of PVL, proliferative varicose leukoplakia. All these malignant transformation rates, that is MTR, you are supposed to know. That is the first point you are supposed to remember in case of the benign and malignant tumors. And frequently question comes on non-premalignant lesions such as tobacco pouch keratosis and nicotinic stomatitis. These are the two characteristic lesions which are due to tobacco, but they are not actually premalignant. So questions come on that aspect, that they are non-premalignant. We are supposed to know about the types of leukoplakia, that is homogeneous, speckled, okay, leukoplakia, verrucous leukoplakia, and their MTR, that is malignant transformation rates, and prognosis also. Prognosis, when what I'm emphasizing here, if you see a nodular leukoplakia, what is nodular leukoplakia? Speckled leukoplakia. It is other name of speckled leukoplakia, where you see both red and white areas. Such lesions are at high risk. They have more malignant transformation rate compared to that of the homogeneous leukoplakia. Okay. Now, proliferative varicose leukoplakia. That is a topic, very important topic, where we are supposed to remember that proliferative varicose leukoplakia will have multiple white patches in the oral cavity. High recurrence rate, high malignant transformation. Almost malignant transformation is 70% average for the PVL. That is why they say PVL is the maximum malignant transformation rate. So in INICET, we can expect a sequence, where we should know that the malignant transformation rate is maximum for proliferative leukoplakia, varicose leukoplakia, then erythroplakia, then speckled leukoplakia, then homogeneous leukoplakia. That is the order that you are supposed to remember. Even in the order, you can expect one more question. The areas in the oral cavity with the maximum chances of dysplasia, like floor of the mouth is a maximum area. Then comes the ventral surface of the tongue. Then comes the lateral border. Then comes the buccal mucosa. Remember, gingiva is the site where labial gingiva particularly is a site where rarely you will see dysplasia. So there is also an order here that you are supposed to remember. Now there is another topic here. They'll ask you about giant cell lesions. Giant cell lesions means what? We have giant cell tumor, osteoclastoma. That is giant cell tumor is other name of osteoclastoma. We have central giant cell granuloma. We have peripheral giant cell granuloma. We have cherubism. We have hyperparathyroidism. All these are the giant cell lesions. We have giant cell fibroma. All these are the giant cell lesions. So here you are expected to know about these giant cells. Actually, these giant cells are from osteoclasts. They are TRAP positive, tartrate resistant, acid phosphatase positive. Here we are expected to know the difference between giant cell tumor and giant cell granuloma. Giant cell tumor is a neoplasm, whereas giant cell granuloma is a reactive lesion. So obviously, as giant cell tumor is a neoplastic lesion, it will have neoplastic cells histologically in the stroma. Whereas giant cell granuloma will not have any such neoplastic cells. Okay, another important point they'll ask you about is a dysplasia and ploidy. Exactly how to predict or how to say definitive about dysplasia is ploidy analysis. What is ploidy? Chromosome number, DNA ploidy, aneuploidy. Okay, they say aneuploidy, haploid, diploid, aneuploid. So ploidy analysis is the ideal way to predict dysplasia. The best way. It is done by an instrument called as flow cytometry. There is a separate instrument for that. You can't do it under the microscope or nothing. You require a separate instrument called as flow cytometer. There is another important topic here, that is immunohistochemistry. IHC can be done in case of melanomas. We know that melanoma basically will have various immunohistochemical markers, that is S100, HMB45. All those markers are very frequently asked. Very frequently asked. Then we are supposed to know about the HPV types, high risk type, low risk type. Like for example, in oral cancer or in the leukoplakia, you will see definitely high risk type. HPV 16, HPV 18 is frequently seen. Low risk type are nothing but all that non-premalignant. Coming on to basal cell carcinoma, again it is important lesion which is frequently asked, that is a rodent ulcer or tear cancer, which occurs typically on the middle third of the face. Here we are supposed to know about the various types of basal cell carcinoma, and specifically we should know the point that morphia form is the most aggressive variant clinically. Most aggressive variant clinically. Moving on to oral submucous fibrosis, the disease which is called as Indian's disease, because it is so common in India. OSMF is very commonly called as Indian's disease, which occurs because of aracanut chewing. We are supposed to know the pathogenesis of this. That means aracanut will have the alkaloids, aracholine, aracadin. How the collagen is made stable here. What is the role of lysyl oxidase? How it causes cross-linking of the collagen. What metal is required for this lysyl oxidase? Copper. What happens to this collagenase enzyme in OSMF? It becomes down-regulated. Its function is reduced. All those things are the highlight topics that are frequently asked here in case of oral submucous fibrosis. We are supposed to know about the syndromes associated with hemangiomas. Mainly the most important syndromes like Stooge-Weber syndrome, Rendu-Osler-Weber syndrome. Frequently we get an image-based question on Stooge-Weber syndrome where they show a unilateral facial stain. So on the face, you will see the discoloration that is called as port-wine stain. It is unilateral. Remember, it is there on one side of the face only. We also have something called as Rendu-Osler-Weber syndrome where we see telangiectasia. What is telangiectasia? These are the dilated capillaries that you see on the lips, mainly hereditary hemorrhagic telangiectasia or Rendu-Osler-Weber syndrome. You will see telangiectatic lesions on the lips. There is another important concept they'll frequently ask is, they will give you a history that a child is there and there is a lesion, pigmented lesion on the alveolus, and urine evaluation shows excessive VMA. What is VMA? Vanil mandelic acid. So whenever you see excessive VMA in urine, it is a characteristically melanotic neuroectodermal tumor of infancy. That concept you should know. See, what I'm giving you is I'm telling you the concepts which you should highlight. I mean, you should prepare for that. Those are the questions that are frequently asked. Ann Arbor staging in lymphomas again is a very classical. We know what is stage 1, stage 2, stage 3, stage 4. We should know that, and we should know that Ann Arbor is done for both Hodgkin's as well as non-Hodgkin's now. Prior it was done only for non-Hodgkin's. Now this Ann Arbor staging is done for both Hodgkin's and non-Hodgkin's. We should know what are the various stages in case of Ann Arbor staging. Moving on to odontogenic cysts and tumors. What are we supposed to know about this in odontogenic cysts and tumors? Mainly about the OKC. Frequently questions comes on OKC. It's a recurrence rate. How much it is? Very high recurrence rate, a grade. But how much? 13 to 30%. 13 to 30%. Why is it so recurrent? What is the reason? The main reason beyond that being the intrinsic growth factor or the mitotic potential of the lining epithelial cells. So that is the reason that we are supposed to know about the recurrence rate in case of OKC. Of course, syndrome is again a very favorite topic, Garlin God Syndrome, where you see the multiple OKCs. Garlin God Syndrome, again that is frequently asked, which is due to the gene. What is the name of the gene? PTCH, that you see in case of Garlin God Syndrome. That is again a very topic frequently asked. AOT, that is adenomatous odontogenic tumor, again commonly asked, because why it is commonly asked is it has got a specific location, specific gender. Typically it occurs in anterior maxilla and that too particularly females. AOT. And now it has been classified as a hamartoma, not a odontogenic tumor. COC, all of us know COC, calcifying odontogenic cyst, which is also known as Garlin cyst. Again, it is very important here. Why? Because it will show a specific location, that is anterior maxilla. And radiograph is also very specific for this. It will have mixed radio-opaque, radiolucent lesion. COC. Okay. Anterior maxilla, mixed radiolucent, radio-opaque. We are supposed to remember three conditions. One is COC, one is AOT, one more is desmoplastic ameloblastoma. COC, AOT, desmoplastic ameloblastoma, all these three occur in anterior maxilla and all these three will have mixed radiolucent radio-opacity. That is a concept they'll usually ask. Ghost cells, again, very important. You are supposed to know the pathogenesis here. Why ghost cells appear? That is because of abnormal keratinization. What are the various lesions where you see ghost cells? It could be COC, it could be odontomes, it could be ameloblastic fibrodontome. In all these lesions, you will see the ghost cells. Ameloblastoma again is a very favorite topic where the frequently question comes on types of ameloblastoma. We have follicular histological type like follicular type, plexiform type, acanthomatous type, granular type. Here we are supposed to know about each type on important unique features. Like follicular type is the most recurrent type. Most common type. Follicular type is the most common type and it's the most recurrent type. Granular type is the most aggressive and those granules are actually made up of the lysosomes. We are also supposed to remember about the Weckerging criteria. Exactly what is Weckerging criteria is? These are the three criteria which are meant for basically the diagnosis of the ameloblastomatous transformation. If any particular cyst develops into ameloblastoma, it has to show all these Weckerging criteria positivity. So we are supposed to know about this Weckerging criteria. Now what exactly is Weckerging criteria? Reversal of polarity of the nuclei. The nucleus shifts away from the basement membrane. Shifts away from the basement membrane. The nucleus becomes tall, columnar, dark, hyperchromatic nuclei. And you will see subnuclear vacuolization. So Weckerging criteria, you have three criteria. Reversal of polarity of the nucleus, tall, columnar, hyperchromatic nucleus, And then lastly, tall columnar cell with hyperchromatic nucleus, and lastly, subnuclear vacuolization. Cementoblastoma is again a very favorite topic where the radiograph of cementoblastoma is very frequently asked. They will give you a mandibular first molar radiograph with a radio-opaque area attached at the apex. That is a characteristic lesion. You should know that about the cementoblastoma. Remember, cementoblastoma, the radio-opaque area will be surrounded by a radiolucent lesion. It will be surrounded by a radiolucent ring. And we should know that cementoblastoma has to be differentiated from a very important type of osteomyelitis called as condensing osteitis. Condensing osteitis. Condensing osteitis also frequently, or it mimics cementoblastoma. But radiographically, we are supposed to differentiate between the two. That is a very highlight question you are expected to know. Again, Pinor tumor. All of us know CEOT, calcifying epithelial oncogen tumor, Pinor tumor, will have presence of some amyloid-like material. And those amyloid-like material are typically stained with certain stains, like one of the classical stain is congruent stain. They'll show you that image that has been frequently asked, and we can expect that apple green birefringence. So on a polarized microscope, the amyloid will take the congruent stain and it will appear as apple green birefringence. Again, that is a favorite topic that you are expected in case of Pinor tumor. Moving on to the salivary gland. Mainly question comes on pleomorphic edema. The emphasis will be on the clinical features of pleomorphic edema. Like pleomorphic edema typically occurs in the parotid, that too superficial lobe. It will be slowly growing. It will be painless. No fixity. No fixity. Nerve involvement is not seen. Nerve involvement is not seen. Pleomorphic edema histologically will show presence of something called as melting type of growth pattern. What is this melting type of growth pattern? Presence of epithelial and myoepithelial cells. Myoepithelial cells are very important in case of pleomorphic edema. We are supposed to know about Perineural Invasion. What are the tumors which will show Perineural Invasion salivary gland? Adenoid cystic carcinoma, that is ACC, PLGA, both of these two will show Perineural Invasion. Both of these two will show same histological ACC and PLGA. Both of these two will show same histological types. Cribriform, trabecular, solid. Then exactly how to differentiate between the two? Because first question comes, why we need to differentiate? Because one is high grade, ACC is high grade. PLGA, polymorphous low grade adenocarcinoma. The name itself will suggest low grade. That means its prognosis is good. So difference between ACC and PLGA is very important. Now how to differentiate? The most important histological difference is the nucleus. In ACC, the nucleus will be hyperchromatic nucleus, whereas in PLGA, it will be vesicular nucleus. What is hyperchromatic? Dark nucleus. Vesicular, light staining. That is the main difference that we should know about the ACC versus PLGA. Then we are expected to know about the mucocele. What is its location? The most common location, blue colored lesion that you see on the lower lip. That is a classical image based question you are expected to know. We are also supposed to remember about the concept of necrotizing metaplasia. Exactly, in necrotizing metaplasia, it typically occurs in males, that too smokers, with a crater-like ulcers on the palate. So you will see deep crater-like ulcers on the palate. That is nothing but necrotizing metaplasia. Sjogren syndrome, what are we supposed to remember? Very favorite topic. What is primary Sjogren syndrome? Autoimmune disease. What is primary? What is secondary? What is a triad for the secondary Sjogren syndrome? Secondary Sjogren syndrome is xerostomia plus xerophthalmia plus rheumatoid arthritis. If you don't see rheumatoid arthritis, what are the other extraglandular manifestations that you see in Sjogren syndrome? Other than rheumatoid arthritis, you will see SLE, you can see polyarthritis nodosa, PAN. You can see basically the other muscle conditions like myositis, polymyositis, Raynaud's phenomenon. All these are called as extraglandular manifestations. In Sjogren syndrome, we are supposed to emphasize on lab diagnosis. Lab diagnosis of Sjogren syndrome is very important, where labial gland biopsy is the most reliable diagnostic tool. Another important topic here is sialadenosis. Sialadenosis. Now, what exactly is sialadenosis? All of us know. Non-neoplastic, non-inflammatory salivary gland is known as sialadenosis. We should know the various causes of sialadenosis, like basically the pregnancy, acromegaly, hypothyroidism, alcoholism. All these are nothing but sialosis or sialadenosis, where it is non-neoplastic, non-inflammatory enlargement of salivary glands. We are supposed to know about Kuttner's tumor. What exactly is Kuttner's tumor? Sometimes what happens is, if you palpate submandibular gland will be very hard. That chronic sialadenitis, sclerosing sialadenitis, the word is sclerosing, of submandibular gland is known as Kuttner's tumor. So we are supposed to know exactly what is this Kuttner's tumor also. Again, they'll ask you about this pilocarpine, very frequently used for the treatment of xerostomia. In Sjogren syndrome and all, you give this pilocarpine to treat this xerostomia. You usually give it in the dosage of 0.5 to 1 milligrams. Again, that is a very frequently asked topic in salivary glands. Moving on to nerve diseases, what are you expected to know? Frequently question comes on trigeminal neuralgia. That it is also known as Fothergill's disease or tic douloureux. Which division of the trigeminal nerve is affected? What kind of pain you will see here? Lancinating pain. Do you see in trigeminal neuralgia any motor defect? No. Muscles are not affected here. What is the Sweet's criteria? There is a criteria called as Sweet criteria. That is the diagnostic criteria for trigeminal neuralgia. We are supposed to know about that criteria. Very frequently asked. Sweet's criteria. Treatment, of course, we know drug of choice, that is the carbamazepine or its variants, that is oxycarbamazepine. And usage of baclofen. How baclofen is used to reduce the adverse effects of carbamazepine. Carbamazepine causes more commonly aplastic anemia. So to reduce the adverse effect of aplastic anemia, they will reduce the dose of carbamazepine, they will increase the dose of baclofen. Baclofen is basically a muscle relaxant which has got an important effect of CNS depression. We are also supposed to know about this Eagle syndrome. What exactly is Eagle syndrome? How it appears on the radiograph? What are its clinical features? They'll give you a history that patient complains of pain while opening the mouth. Okay, all those things you are supposed to remember about the Eagle syndrome. Moving on to skin diseases, what are we supposed to know at skin disease? Mainly topic of skin disease classically is pemphigus. What are the various types of pemphigus you see? Pemphigus vulgaris, pemphigus vegetans. Which are the types which will have oral manifestation is vulgaris and vegetans. Where do you see cerebriform tongue? Cerebriform tongue is characteristically seen in pemphigus vegetans. What is DIF? It's not DOF, DIF. Direct immunofluorescence finding that you see in case of pemphigus vulgaris. We know that these vesiculobulous lesions have to be diagnosed by DIF, direct immunofluorescence. So in pemphigus vulgaris, we see something called as chicken wire or fishnet appearance. What is pulse therapy? Pulse therapy is we give high dosage of certain drugs, intermittent way. That you give in case of pemphigus. You are also expected to know the areas of splits, which are the skin disease which will show intraepithelial split. For example, pemphigus, intraepithelial split or suprabasilar split. Intraepithelial or suprabasilar, both are the same. Subepithelial split, pemphigoid will have subepithelial split. Paraneoplastic pemphigus, it will have both. So you are supposed to know which are the skin disease which will show intraepithelial, which will show subepithelial, which will show both. We are also supposed to know about the types of lichen planus. Wickham striae that you see in case of reticular lichen planus, atrophic lichen planus that causes the desquamative gingivitis, erosive lichen planus which is a pre-malignant condition. Okay, all these we are supposed to know. Of course, histology of lichen planus is very important, where the liquefaction degeneration of the basal cells is seen. And we see apoptotic bodies called as colloid bodies in case of the lichen planus. Scleroderma will show a characteristic OPG finding. What is scleroderma? We know that systemic sclerosis, where there is excessive deposition of the collagen, the ramus of the mandible becomes thin, and that OPG will characteristically show called as tail of a whale appearance. Tail of a whale appearance. Again, that is a characteristic OPG finding you are expected to know in case of scleroderma. Infections, we are supposed to know mainly about the actinomycosis, where typically they'll show an image of multiple draining sinuses, and those draining sinuses will have pus, and the pus will contain sulfur granules. Syphilis, we are supposed to know about the oral manifestations, mainly the primary syphilis, secondary syphilis, tertiary syphilis, where you will see chancre, that is primary syphilis. Mucus patches are seen in secondary syphilis. Gumma is seen in case of tertiary syphilis. And that gumma that you see on the tongue is nothing but interstitial, causes interstitial glossitis. We are also supposed to know about the HSV, that is herpes simplex virus, various types. About the Lipschutz bodies that you see, that is intranuclear inclusion bodies that you see in case of HSV. We are also supposed to remember about the spots, Koplik spots that you see in case of measles. Herpangina, which typically affects like pharyngitis, mainly it is Coxsackie virus induced. So typically they'll give you an image of the they'll give a history that typically the patient will have pharyngitis. Those vesicles are there in the posterior part of the pharynx. That is nothing but herpangina. Candida, we are supposed to know various types. Oral thrush, that is Pseudomembranous candidiasis. Antibiotic sore mouth. Denture sore mouth. Okay, all these are the various types of candidiasis we are supposed to know. What is the cause for those candidiasis? How it appears? Denture sore mouth, there is a classification you are expected to know. Newton's classification for denture sore mouth. Mucormycosis, aspergillosis are the two fungal infections which occur in uncontrolled diabetes and immunocompromised patients, respectively. Both will have typical same clinical features. How to differentiate between the two is the histology. In mucormycosis, the hyphae are large, ribbon-like, and they don't have any kind of, they have branching basically at the obtuse angles. Whereas in aspergillosis, you see thin hyphae which branch at acute angles. Metabolic disorders, certain topics are asked, like hypophosphatasia. Typically, what do you see in hypophosphatasia? Early exfoliation of the mandibular incisors. That is a characteristic feature. Brown's tumor that you see in case of hyperparathyroidism. Why do you call it as brown? Because of hemosiderin pigment. Hurler syndrome. What is Hurler syndrome? Mucopolysaccharidosis. So you will see certain oral features in Hurler syndrome, like thick lips. Sarcoidosis. What are the various oral manifestations? What is Hereford syndrome? Hereford syndrome is basically uveo-parotid fever. It's called as uveo-parotid fever, where uveal tract infection is seen and the parotid gland enlargement is seen. Again, that is a very favorite topic that is frequently asked. Moving on to the last, the forensic odontology. Frequently question comes on age estimation method. Mainly you are supposed to know about the Nollas method. Demirijan or Gustafson's method. Gustafson's and Demirijan's method. So here, previously question has come on the Nollas method and Gustafson's. Gustafson's method criteria are very important. And you can get question on bite marks and lip prints. What you can expect? Bite marks, what are the various, mainly the impression materials. Bite mark, usually for bite mark you require impression material called as polyvinyl siloxanes. Polyvinyl siloxane. And bite mark can be measured by a scale called as ABFO2. So there is definitely, Bhavna, I'll go through them. What are your doubts on the group will be definitely, I'll just look into that. Okay, just give me 1 or 2 days, but tomorrow all your doubts will be cleared. Bone, what are we expected to know in osteogenesis imperfecta? Mainly its pathogenesis. That is, what is the role of col1A1? What is the role of col1A2? In osteogenesis imperfecta, whether mineral deposition is abnormal or matrix. It is matrix. Mineral deposition is normal. So the genes that are mutated are very important. What are the genes that are mutated in fibrous dysplasia? There is GNAS1 gene. What are the gene that is mutated in cherubism? SH3BP2 gene. Osteogenesis imperfecta. What are the genes? COL1A1 and COL1A2 genes. We are supposed to name mainly 3 syndromes: Krausen, Appert, Treacher-Collins syndrome. These 3 syndromes are frequently asked. Mainly the Treacher-Collins syndrome, that is mandibulofacial dysostosis. Appert and Krausen both are similar. Both will have craniosynostosis. But Appert will have syndactyly, which is not seen in case of Krausen syndrome. And Paget disease, we will get questions on its alkaline phosphatase levels, highest levels of these alkaline phosphatase, and Lincoln sign. That is on scintigraphy, you will see Lincoln sign in case of the Paget disease. Again, that is very frequently asked. Lastly, we have some miscellaneous topics, highlight topics like plumbism, lead poisoning. They'll tell that Burton's line, it is called as Burtonian's line or Burton's line. Acrodynia, mercury poisoning. Argyria, silver poisoning. And tetracycline stain, that is frequently used. That is frequently seen in that is a tetracycline stain, where you see the yellowish brown discoloration of the tooth. Remember, tetracycline should be never given till 8 years of age. And if you do use a UV light, and if you put that UV light on the tetracycline stain, the stained tooth will show yellowish fluorescence. That is a point you are supposed to remember about the tetracycline stain. Okay, so that is about an overview of some important highlight topics, high yielding topics that you are expected to know in case of the oral pathology and oral medicine. Okay, these topics you are supposed to know. Okay, these can be expected. These are the areas where frequently the examiner finds the MCQs. See, whenever a question comes, whenever an examiner wants to ask a question on osteogenesis imperfecta, first part what he'll think is of pathogenesis. Okay, so these whatever I have given you in this presentation are those topics which are the high yielding topics for the subject of oral pathology. Okay, thank you so much. Any doubts? Your doubts will be clarified in the group. Have patience, 1 or 2 days, everything will be cleared. Thank you.